Thank you for your kind introduction. And it is my great honor to be here today. And my topic is the integration of HIC in unresectable HCC management. Next. 好像还在那个画那个，所以不行。Okay, this is my disclaimer. And my talk will focus on three parts. The first, introduction of our modified HIC technique in our hospital. And the second, I will review the efficacy of HIC in HCC patients across different stages. And the third part, I will discuss the HIC role in the combination therapy in the era of immune checkpoint inhibitors agent in both advanced stage HCC and some selective cases in intermediate stage HCC. And in the end, I will show you several cases from our real-world clinical practice. In the updated 2022 BCLC guidelines. For intermediate stage HCC, conventional TACE remains the standard treatment, while systemic therapy has become the first-line option for advanced disease. And in the latest 2025 TLCA guidelines, for CTACE candidate patients, if their tumors are high tumor burden with poor radiology pattern, then combination strategy 2 plus TACE and systemic therapy is recommended to improve the outcome. So from this update, we know that a combination therapy is important for large HCC, for bilobar HCC, or HCC in the major vascular invasion. Monotherapy often not enough. We need stronger combinations. And I will first introduce our modified HCC version. Our HIC version is modified, inspired by both conventional TACE and the classical HIC approach. We usually insert a temporary catheter rather than a permanent port system. Our indication is high tumor burden HCC in our hospital, like HCC beyond the up to 7 criteria and HCC with major portal vein or hepatic vein invasions. We usually insert the catheter via the left accessory artery, distal to the thoracoacromial arteries under ultrasound guidance. And usually a 4 French or 5 French catheter was inserted into the celiac artery. And then we routinely embolize the gastroduodenal artery and the right gastric artery, and sometimes also the accessory left gastric artery to prevent the non-target infusion injuries to the small bowel or pancreas. And sometimes we also plus a microcatheter for more selective access. The tip of the catheter will be placed at the common hepatic artery or proper hepatic artery. And then continuous chemoagent infusion will be given in the wards for 3 days or 5 days, depends on the regimen they choose. And after complete the chemo infusion, the patient will return to our angio chute. And we will inject less than 10 millimeters of lipiodol before the catheter was removed. And this step was meant to cause microvascular embolization rather than flow stasis. And second, I will review the efficacy of our HIC protocol. And the first case is a 67-year-old female with a huge HCC pedunculated from segment 4 and segment 5. Also accompanied with right portal vein invasion, BP3, and Charpio score B, and BCLC stage. And the angiography shows the huge tumor was partially supplied by the GDA, gastroduodenal artery. So we embolize its distal branch and place the catheter, preserve the hepatic feeding artery for HIC. And after 4 courses of HIC, the lesion shows dramatic shrinkage, evident tumor shrinkage. And she had 17 months of tumor-free survival, no local recurrence. Now she has 2 small new lesions at S3. This is another case is a 51-year-old man who had infiltrative HCC, infiltrative growth along the left portal vein and the bile duct, with also bile duct invasion. And he experienced HIC therapy for 8 cycles, and all the intrahepatic tumor shows completely disappeared. And the patient also subsequently developed lung metastasis, and he received the lenvatinib and also achieved a complete response. And however, 20 months later, a new lesion developed at S1, very close to the IVC, a risky area for both operation and ablation. So the patient returns to receive HIC therapy again. And after 4 cycles, the tumor shows evident shrinkage. So I performed a curative RFA for him. And now he enjoys his tumor-free survival today for more than 7 years. And the other case is a 40-year-old man with HCC 10 centimeter with the main portal vein invasion, and he experienced HIC for 6 cycles, and all the tumors in his portal vein and the liver has gone. He has a 10-year tumor-free survival. Another case, multiple HCC with the tumor inside the IVC and reaching the right atrium. So the patient received HIC for 5 cycles, and all the tumor shows evident tumor shrinkage, tumor regressive. Tumor has regressed completely and preserved the hepatic vein and IVC patency. In reviewing our result, in the portal vein, in the major portal vein tumor thrombosis, BP3 and BP4 cases, this kind of patient usually has more than half of the patient has tumor size more than 10 centimeters, and some of them also shows extrahepatic spreading and hepatic vein invasion. The response rate of our HIC is about 66.4%, with the mean progression-free survival about 8 months, mean overall survival about 14 months, and even longer in child 8 patients. In contrast, this kind of population, if under best supportive care, the median overall survival is usually less than 4 months. Even in the worst scenario with tumor thrombus in the main portal vein, BP4, the overall response is still very high as 67%. And the median progression-free survival is 9 months, and the median overall survival is 13 months. In contrast to the same subgroup analysis in BRAVE 115 study, the overall survival of Tezo-Bev was only 7.6 months, and the overall survival with sorafenib treatment was only 5.5 months. The adverse event of our HIC was very mild, only grade 1 and grade 2, manageable complications. In other ways, for a huge HCC more than 10 centimeters, this kind of large, huge HCC are more frequently associated with vascular invasion, multifocal, and high grade, more aggressive. And even if resectable, after resection, the early recurrence rate was very high as 50% at 12 months. And leaded to poor 5-year overall survival for this kind of patient. And in this kind of populations, neoadjuvant HIC may play as a role. Neoadjuvant HIC, such as in this case, this patient has an infiltrative HCC occupied all right lower liver with the right portal vein and the main portal vein invasion. And he experienced HIC treatment for 3 cycles. The lesion only showed a stable disease on the image, and the surgeon find it could be a chance to do a resection. So the surgeon did a right hepatectomy, and the patient had 5-year tumor-free survival. Another patient has an infiltrative HCC in the right lobe with IVC invasion and a major portal vein invasion. And after 6 cycles of HIC, all the intravascular thrombus shows evident shrinkage. And the patient received the right hepatectomy, and the patient got a 7-year-old tumor-free survival too. So we review our neoadjuvant HIC case retrospectively. We know this kind of patient, compared to the patients who received the surgical, primary surgery, immediate surgery at the initial diagnosis, this neoadjuvant group patient had a more worse condition with more multiple tumors, more bilobar tumors, more VP3 and VP4 tumors, and then more HR hepatic spreading and more hepatic vein invasion. That's the reason exactly why they were unsuitable. They were unable to receive immediate surgery. So in this kind of patient, the object response rate is still very high, 60%. And surprisingly, the early recurrence rate in this worst group is much better than the patient who received surgery initially, about 20% only, compared to the surgical resection only group. And these two, and this result will translate to better disease-free survival and better overall survival. And then we will raise a question that in the era of immune checkpoint inhibitor, so many immune checkpoint inhibitor, is there still a role for HIC? And we know that HCC is generally not inflammatory tumors. Only about 20% of HCC is inflamed and is eligible to immunotherapy. So how to convert a cold tumor into a hot tumor is a major challenge for immunotherapy. Then HIC may cause cell death, release more antigen, present more antigen, and then may cause immune agent to be more active. There have been several early studies show the result of combination therapy with atezo-bev and HIC. One of the papers is from mainland China, and they had 52 patients unresectable HCC. And most of these kind of patients have tumor thrombosis, and the conditions are not very good. More than half had main tumor size more than 10 centimeters, and about half of them have extrahepatic metastasis. How to combine these two strategies? They use their protocol as follows: with atezo-bev every 3 weeks, and use FOLFOX HIC every 4 to 6 weeks. And their response rate is similar to us, about 67 point. And the response rate is very high compared to the IMBRAVE 150 trial. In the IMBRAVE 150 trial for advanced HCC, the object response rate for atezo-bev is only 27%. Also, the progression-free survival is prolonged to 10 months. This is one of the examples. In this patient, there are multiple multiple lung metastasis and multiple intrahepatic lesions. And after the combination therapy, all the lung metastasis and the intrahepatic lesions has disappeared. The adverse event is manageable and mild. Some elevated ST and ALT, and some mild proteinuria and thrombocytopenia related to the immunotherapy. And the most advantage for this treatment is remarkably increased the object response rate from 27% to 67%. So this triple therapy combination of both atezo-bev and HIC for advanced HCC could be an alternative and a promising treatment. And then let's shift to the intermediate stage with high tumor burden. The TALENT test is the first phase 3 randomized control trial to compare the on-demand test combined with atezo-bev or on-demand test only in the intermediate stage HCC. Their patient group inclusion criteria is BCLC A or BCLC B stage, or BCLC A or BCLC B stage, or only BCLC C for VP1 and VP2 only. These patients were randomized into 2 groups. One is on-demand test plus every 3 weeks atezo-bev, and the other group is on-demand test only. Their primary endpoint is test-specific progression-free survival and the overall survival. The definition of TASE, PFS, TASE-specific progression-free survival, the definition is that the time from randomization to untestable time, untestable. which means the test is refractory or progression, including the intrahepatic lesion progression, or the test shows refractory failure, test failure or refractoriness, or appearance of extrahepatic spreading, or the major vessel invasion shows progression, or the liver function declined to CHOP B8 or worse, or a death from any cause. So their results showed that in the combination group, the combination therapies can prolong the testable duration and allow the patient to receive more transarterial treatment, more repeated treatment from 7 months to 11 months. And also the progression-free survival also prolonged. Disease progression-free survival also prolonged in the combination group from 6 months to 10 months. And more important is the response rate is much higher than the on-demand test only, from 60% to 81%. So in a small conclusion in the talent test, that the talent test result shows that the combination therapy may create more opportunities for treatment while minimizing the risk of liver decompensation. And finally, I will show you 2 of our cases with HAIC combined with atezolbev. The first case is a 69-year-old male with 2 huge HCC, exceeding up to 11 criteria. And after 4 cycles of HIC, even the tumor marker shows gradually declined. However, on the CT study, there is only stable disease. No evident tumor size shrinkage. So the clinical doctors added atezolbev for him. And after several times atezolbev, the lesion shows dramatic deep partial response. The lesion size shrink evidently. The second case is a 63-year-old female with HCC, occupying the right lobe with right portal vein, major portal vein invasion, and also another big tumor at S2. And the pathology is poor differential HCC. And after she received atezolbev initially for 4 cycles and focal radiation for the main tumor thrombus, main portal vein tumor thrombus. However, the response was only stable to mild progression. So the clinical doctor asked us to add HIC for her. And then after 3 times of HIC, her tumor markers declined to normal. And in the following CT, we can see that the pretreatment study is the first, in the first line is the pretreatment images. And the second line is the after 4 cycles of atezolbev, only showed mild progression, stable to mild progression. And after 3 cycles of HIC, the lesion shows clear tumor shrinkage. And the patient shows complete response until now. So in summary, the combination therapy has become an important option for advanced HCC. And on-demand test plus atezolbev or HIC plus atezolbev are promising for HCC to elevate the object response rate. The potential benefit is remarkably increased response rate of immune-only therapy and improve tumor control during immunotherapy. However, the potential concern is the may decrease immune target, increase neoangiogenesis effect, or HIC-related complications. And the right timing of combination therapy is guided by intrahepatic tumor burden and the response assessment and the multidisciplinary collaborations. And for this kind of patient, if we can choose carefully, combination therapy may extend the survival. And possibly we can create more hope for our patients. Thank you for your attention.